Good evening, everyone, and welcome to IH Grand Rounds. This is our first rounds of the new season, September, as we head into fall and the smoke is finally cleared, at least in the Okanagan. Today's rounds will be an update on medical assistance in dying, led by Dr. Sarah Broder, respirologist and Senior Medical Director for End of Life and Palliative Care, as well as Dr. Andrew Robertson, who is a Regional Medical Director for Palliative and End of Life Care. What I'd like to do is start with our Aboriginal acknowledgement, and we'd like to acknowledge the traditional territories of the First Nation peoples within the interior region on whose land we live, work, collaborate, and play. And we also like to acknowledge that we are responsible for the stewardship of the land, as well as the individuals who live upon it and the animals and the flora. I will now review the agenda in terms of information and privacy, a few tips about Zoom. We've done a bit of introductions, go into the presentation, have questions and answers, and there'll be an evaluation in the end, as always. The IH Grand Rounds will be recorded and shared publicly. The presenter and facilitator names will be shared. Attendee names will not be published, although voices will be recorded during the question and answer portion of the session. The actual session, once it is posted, will be available as well as a PDF of the presentation. Any questions that you may have can be directed to one word, we're all connected together, medicalstaff@interiorhealth.ca. I'll repeat that, medicalstaff@interiorhealth.ca. So without further ado, we will start the IH-wide medical rounds and the new legislative changes. And it's hard to believe that it's only been a few years since the legislation regarding medical assistance in dying was passed, and what Heidi Otter at the College of Physicians and Surgeons said was the greatest change in the practice of medicine she'd seen in her whole career. So I will now turn over the rounds to Dr. Sarah Broder and Dr. Andrew Robertson. It's over to you, Sarah.
Thank you, Harsh. I wanted to just disclose that neither Andrew nor myself have any conflicts relevant to this talk, other than that we're both involved within IH and palliative and end-of-life care services. So we're going to do quite a rapid fire overview. We're going to do a historical overview with respect to the legislation in medical assistance in dying that led to the passing of Bill C-14. And then we're going to talk about some important legislative changes that have happened since C-14 came into effect in 2016. We're also going to talk about some myths with respect to MAID, and then we're going to get into some nuts and bolts about what's involved in setting up a MAID, what's involved for the patient, to be an assessor, to become a provider, and mistakes that can happen along the way. And at the end, we're going to talk about IH experience with medical assistance in dying over the last 4 years and present the data that we have collected. So historically, you often kind of think about where you were when things happened, like where one was and when 9/11 happened and you first knew that the towers were coming down. In 1993, which shows that I'm a little on the older side, I remember when Sue Rodriguez went to the Supreme Court and she had ALS and she asked for medical assistance in dying and she was denied. It was a 5-4 decision. And she said, if I can't consent to my own death, then whose body is this and who owns my life? And during that time, I was actually on a palliative care rotation, and there was a lot of discussion back and forth amongst the physicians that I was working with. Flash forward to 2015, This actually went to trial quite a bit earlier, and I was now a respirologist working in Penticton, and it was actually several patients with ALS that were going to the Supreme Court, and Gloria Taylor was the lead, but there was other patients in the South Okanagan that were involved in this, and I got asked to be a medical witness, but only about a week before you had to submit all of the papers, and there wasn't enough time for me to be able to be supportive of it. But Gloria Taylor, who was in Kelowna, asked for medical assistance in dying, and this time it was a unanimous ruling in her favor that she could have medical assistance in dying should she wish it. So this led to the government having to come up with a bill to make it no longer illegal for a physician, a nurse, and a pharmacist to be involved in medical assistance in dying, because in past, if you had participated, you would have been committing offense and committing murder. And it led to some very specific criteria being established that must be respected, and these criteria still are in place. So Bill C-14 establishes the following prerequisites for medical assistance in dying to happen. First of all, the person has to be eligible for health care in Canada, and that's a very important point, because Canada does not want to become a medical destination for medical assistance in dying. And we recently had a very challenging case where somebody had a clearly metastatic cancer, had been in Canada for 3 years, but she had never applied for health care benefits. And this person is not eligible for palliative care services, nor admission to hospice, nor is she eligible for MAID. The person must be over the age of 18. It has to be a voluntary request. So the family can't be the one to say, oh, I think that the person would like MAID. We can't be the one to request it. It has to come from the patient. And the patient must be capable and competent of making this request. They have to have a serious illness, disease, or disability that's in an advanced state of decline, and we'll talk more about that. And they have to have intolerable suffering from this illness. And this is a point that is very contentious at the time, was that the person had to have a reasonably foreseeable death. So Bill C-14, when it came out in 2016, does not in any way address people who are mature minors. You have to be over the age of 18. It does not deal with when mental health issues are the sole reason that somebody is looking to have medical assistance in dying. And this is in no way addressing concepts like an advance directive in the setting of dementia, where when I am of sound mind, say, when I get to this point, this is when I would like medical assistance in dying. You can't do that at this point in time with Bill C-14. Now, there have been some very important legislative changes that have happened since 2016 when this became a law. And one of the first ones that I want to focus on is those that are conscientious objectors to MAID. And the Supreme Court of Ontario made it very clear in April of 2019 that if one is an objector to MAID, then you must provide an effective and a timely referral to somebody that is knowledgeable and capable of dealing with the patient's requests. And I think of this as being similar to abortion, or I have teenage kids and the use of birth control. If you're not prepared to deal with these things, you need to pass the patient on to somebody who is willing to deal with those topics. The concept of grievous and irremediable suffering has been a very important point when being an assessor and a provider. And there have been two really important legal challenges. In 2016, when I first started becoming an assessor, I was always really coloring very much within the lines. And I thought of a reasonably foreseeable death as being something where a person would die within the next 6 to 12 months. But this case, AEB at the Supreme Court of Ontario that came through in June of 2017, the person, all that they had was very severe osteoarthritis. And the person, it was felt that they had irremediable suffering, and that was enough, that frailty was enough of a problem that that person was eligible. And that really blew open how MAID assessors and providers looked at patients, and it put a timeline of about 5 years that you could imagine that that person would die. And then there was a more recent case in September of 2019 of Truchin and Gladue versus the Quebec Supreme Court. And these two people, I think it's worth it to understand who these people are. Truchin was a 73-year-old lady who had had polio at age 4, and she had a progressive and severe scoliosis. She had had, I believe, a stroke and was paralyzed on one side, and she had a very large hiatus hernia. And she was now confined to a wheelchair. With her kyphoscoliosis, she was even more hunched over, and she had severe respiratory limitation in her function. And so for her, at 73 years of age, one could actually imagine her foreseeable death. But Gladue was a different case altogether, and he was 51 years old without any major underlying problems other than the fact that he was born with cerebral palsy. And he had full movement of his left arm, but he had a progressive spinal stenosis at the level of C2, and he was now losing the ability to use his left arm, which he used to operate his wheelchair. And he was now confined to a puff and blow wheelchair. And he had contemplated many ways of ending his life, including voluntarily stopping eating and drinking or using various street drugs. And what the court found was that both of these people had intolerable suffering, and even though their death wasn't reasonably foreseeable, that the law as it stood was infringing on their charter rights. So this has led to a review of the legislation, and Bill C-7 is what is going to ultimately come out of this. The federal government was given 6 months to rewrite the laws or challenge the Quebec Supreme Court, and the federal government did not decide to do that. And they had initially until March 2020 to come up with new legislation. They had the first reading of the bill in February of 2020, and then, as we all know, COVID hit, and the government really ground to a halt on anything of this sort. And so the federal government has been given 2 extensions to sort out the legislative details, and the current deadline is December the 18th, 2020. Taking you through what Bill C-7 is proposing, on the patient front, the patient will only need 1 witness to confirm that the patient is actually the one asking for medical assistance in dying. And this person can be a paid person or a healthcare provider as long as they are not directly involved in the patient's care. And it creates 2 pathways for medical assistance in dying with different safeguards in place for each one of them. And to take you through that, if this goes through as the original reading shows, there will be those that have reasonably foreseeable natural death, and those patients will no longer require a 10-day waiting period between the time that they sign the paper and the provision of MAID. And if the person loses capacity to consent for MAID and a date has already been chosen, you can still proceed with the medical assistance in dying. And this prevents patients who have, for instance, brain metastases, or a patient who has a lot of pain and is afraid to take their medications because they're concerned it's going to lead to a delirium, that these people will not have to proceed with MAID sooner than they wish. Those that do not have a reasonably foreseeable natural death will need to wait a minimum of 90 days before MAID can be provided. And during that time period, this is something that is going to be very challenging for us to all sort through, is that one of the assessors must have expertise in the disorder, and the patient has to have explored all reasonable treatment options to alleviate their suffering, including the concepts of palliative care, counseling, and mental health supports. I think that the way that I view it, I think that a lot of family doctors will actually be able to be those types of assessors, because they will know all of the people that the patient has been seeing and will have all the consultative reports. But there will be some that will be very challenging to find somebody who can do that assessment, who has expertise in the field. And in this pathway, the patient must remain competent right up until the procedure is performed. Now, I want to make it very clear that Bill C7 still does not address issues related to mature minors. It still does not provide advanced directives in the setting of dementia. And if the psychiatric disorder is the sole underlying condition leading to a MAID request, it does not deal with that either. Consequences of Bill C7 is that it still needs to be discussed at a parliamentary level, and there are still two further readings that have to happen. So until then, for all of us here in British Columbia, it's business as usual, following the criteria set in Bill C14. And what I want to emphasize for those who have been experienced MAID providers, don't do what I did initially, and that is put any forms having to do with MAID into my EMR. Always go directly to the BC government website for the most up-to-date forms for patient request, assessing, and prescriber forms, because when Bill C7 does come into effect, there will be major changes in all of those forms. Now, COVID has also impacted some significant changes on how we do assessments. For instance, with respect to a patient request, in past, the two witnesses had to be there to see the patient sign the forms. Now the witnesses can be there in a virtual sense, and they can be on a video link. And if the patient who is requesting is in, say, an acute care hospital, hospice, or a long-term care facility, an employee who is not involved in the patient's care can be that witness. For assessors and providers, both of these can be done as a virtual assessment. If you know the patient, you can do it just by phone, but if you've never met the patient, I would suggest a video link to make sure that you're talking to the person that you think you are, and that they provide some proof that they are who they are. And for providers, they do need to wear personal protective equipment for the provision, with masks and gloves, and try and maintain appropriate social distancing. In past, the medications had to be returned to the pharmacy by the physician who took the medications, but if you are unable to be that person, you can delegate another provider to do that. And propofol has been in quite short supply at times, and there have been concerns about propofol supply, so they are no longer routinely disposing of the second kit if that kit has, if it has not been tampered with at all. A question that often comes up is what I call the elephant in the room. And the question is, can I bring up the topic of medical assistance in dying with my patients? And if a person would meet the criteria for medical assistance in dying, if it is in the full context of medical care, so for instance, as a respirologist, I look after lots of people with end-stage lung disease, and as long as I am talking about the medical, the palliative, end-of-life care pieces, MAID then becomes a part of that full and honest discussion about what therapies are open for our patients. Now I'm going to pass it off to Andrew, who's going to talk about the nuts and bolts of doing an assessment.
Thank you very much, Sarah. So I'm going to just start at the beginning from when a patient approaches me or when we're discussing MAID, and just finding the forms for a patient, because sometimes they just don't know where to find them. So it's pretty basic. If you Google MAID forms BC, the first thing that pops up is the Government of BC website, and if you just click on the top of the hits, that's where you'll find all of the relevant MAID forms. So everything from the patient request to the assessor forms to the provider forms. So I always print out those forms for the patient request form. And I also print out the instructions for the patient too, because there are lots of details that potentially the patient can miss, and it walks them through it step by step. So there's a copy of the patient request form. There's lots of details that maybe you can't see, but I'll go through some of the common errors that patients make when filling in these forms.
No, don't. You can just use the mouse to point out. Okay, don't use the mouse. Okay.
So common mistakes that patients make, as Sarah already mentioned, not using the most up-to-date forms. So that's why you shouldn't download them and have them in your EMR in your office. These forms do change, and yeah, you want the most up-to-date one. Another common problem is that the proxy or the witnesses both don't meet the legal requirements. So proxies and witnesses can't benefit from the patient's death in any way. So yeah, common people that I see being used are neighbors, friends, oftentimes people that don't actually know the patient that well. If there's an issue with finding witnesses to be there when the patient is signing the form, Dying with Dignity Canada will find witnesses that can help out, because sometimes it is a bit of an issue if the patients are alone and they don't know anybody. Other common mistakes are the patient and the witnesses haven't signed on the same date. You might find that a bit funny, but it actually happens quite frequently. And then when this does happen, patients have to go back and they have to do them again, unfortunately. Other things, yeah, just dates, signatures. It's very important that at the end of the, I'm gonna go back. At the end of this form, there's a place for the preferred contact for the patient. That comes in quite handy when either the assessor or the provider is trying to get a hold of the patient. So that being a son, a daughter, a spouse, somebody that you can contact to set up a meeting with the patient, because otherwise sometimes it's a little bit difficult. So after the patient's request for MAID has been filled in, it has to get to the MAID office within Interior Health. The fax number is at the bottom of the form. So then the patient can fax it there. I commonly fax them from my office. Well, I don't, but my MOA does. And so then the MAID Coordination Center in Kelowna, they will find both a primary assessor and the provider. It's nice that now the majority of family doctors will act as the primary assessor when asked. And yeah, so more family doctors are getting involved with their patients. If the family doctor isn't willing to be the primary assessor, then the MAID Coordination Center will find another physician or a nurse practitioner to do the assessment. So then after the MAID Coordination Center receives the patient request, we move on to the primary assessor. So the baton is passed to the physician or nurse practitioner who's going to be doing the primary assessment. So first thing that happens when I receive the forms is I always go through them with a fine-tooth comb, I think. Oftentimes I miss stuff too, and they get faxed back to me. But I go through them for mistakes that have been made, and yeah, I try my best to pick up on those. And so then the primary assessor will then have to do their assessment and make sure that they are meeting all of the criteria to proceed with a medically assisted death. And so the form again can be found on the Government of BC website, and that is Form 1633. You can bill for your time, and so you don't need any special training to do the primary assessment. The billing is, you can bill up to 7 times of the 15-minute units, and the billing code is 13502, if anybody's interested. So then, yeah, one of the jobs of the primary assessor is to make sure that the patient has the capacity to make the decision to end their life. And so, are they capable of making the decision? The patient must understand the diagnosis and their prognosis. They must understand the consequences of accepting or declining treatments. And so one thing that I like to do is I like to just make sure that the patient has been at least offered palliative care. It's not always that patients want palliative care, but they should at least be offered, and they should know all of the options. Sometimes patients don't want palliative care and they just want to proceed straight to MAID, and if they meet the criteria, they can do that. And so the alternatives to an assisted death, so palliative care. And they must be able to communicate their choice. So whether that's verbally, in writing, sometimes patients can't speak, but as long as they can convey that to whoever's doing the primary assessment. And as Sarah mentioned, patients must maintain their capacity right up to the time that the provision of MAID is, it happens. And so this is sometimes a bit of a concern for patients, because if they are worried that they're going to lose the capacity, they may feel that they're rushed to proceed with MAID, which isn't a very nice feeling if you are in that situation. And if capacity is ever in doubt, it's pretty much mandatory to get a psychiatrist involved to do a capacity assessment. There are specific forms for that, and those again can be found on the Government of BC website. And so then they can make sure that the patient is capable of making the decisions that they're making. So then the other thing that must be assessed is the patient in an advanced state of irreversible decline? So how does their condition affect their daily functioning? So can they do the things that they could not do in the past, like simple things like getting dressed, making meals for themselves? And so you want to explore that a bit with the patient as to how things are going in their daily life. And so sometimes patients have some sort of ailment that potentially would qualify them for a medically assisted death, but they don't meet the criteria currently. So it is reasonable to do repeat assessments over time. So say in 6 months, maybe this patient is going to meet the criteria for MAID. They don't meet the criteria now, and sometimes that's really hard for patients to hear that no, they can't have this done. But then you can reassure them potentially down the road that they will meet the criteria, and yeah, so you can go back and you can do reassessments. So then after the primary assessor has done their assessment, all of that paperwork is again faxed off to the MAID Coordination Center in Kelowna, and so then it's up to the provider to do another assessment. So these are the duties of the MAID provider. So they do a second independent assessment to the primary assessor, and again making sure they meet all of the criteria for a medically assisted death. And so the provider also will go through a timeline with the patient, so a location and a date. And sometimes that's not right away. Sometimes patients don't know when they want it. Sometimes patients never even go through with a medically assisted death, despite having gone through all of the paperwork and had all of the assessments done. Sometimes they're put on the back burner, like a little safety net. If things are getting too uncomfortable for them, then they've got it there waiting on the back burner. And that's a nice comfort to have, I think, when patients are nearing the end of their life. And so normally the medically assisted deaths take place 10 days after, or they can take place 10 days after the patient has signed the forms, the initial patient request. There's two ways that they can get that expedited, so less than 10 days. And so the first being if death is imminent, so if these patients are declining rapidly, then it can be done virtually right after they've had both of their assessments done. Then also if capacity is going to be an issue, so the patient is, deteriorating, and if, say, someone has brain metastases and their capacity might not be there in 2 weeks, so you can do it faster than 10 days, and just both assessor and provider have to agree that, yeah, they meet those criteria. And so again, the provider can bill for their time, and so they can bill up to 9 units of these 15-minute increments, and that's the billing code there. And so medications. So when you're getting closer to the provision, you have to arrange for medication. So if it's in the community that you're going to be doing it, like at the patient's house or even one of the long-term care homes, medications have to be arranged through a community pharmacy. If it's done in an acute care setting, like for an example at the hospital here in Penticton, you have to use the pharmacy that's associated with the hospital. And so when you've arranged the medications and you're going to do your provision, you can bill again for picking up the medications, but that only happens in the community. It does not happen if you're doing it in an acute care setting. And so when you've got all of the dates set and the location, the MAID Coordination Center will arrange for nursing support, which is, I think, well, completely invaluable. I don't know if every single physician uses that, but I definitely do, and I can't really think of any physicians in the area here who don't use nursing support. They usually go in the day before of the provision to start intravenously to give medications, and they're there when the provision takes place too. And yeah, as I said, they're invaluable, and they're extremely good for support for, I feel like, myself and also for patients and family members. There's two ways of delivering medication, so intravenous and oral. In all of my years doing this, I have not had a single patient who has requested the oral route. And when you're presenting the options for patients, when you tell them that the oral route can take sometimes up to a few hours to work, they might end up with severe nausea and vomiting, that seems to discourage them. And so according to the Coordination Center or the MAID office, in the last 4 years, there's only been 3 patients in Interior Health who have chosen to do the oral route. And so then the duties of the provider, they have to fill in all of the paperwork for pre-MAID, post-MAID, document where it was done, how it was done, like intravenous versus oral route, and then also fill in the death certificate. So that's something I always bring when I'm doing my provision, is a death certificate that I can leave for the family or whoever's going to be there when they come to pick up the body. And so then there's the billing code for the provision. You can also bill for a same-day visit, whether that's in the home or the acute care setting, and that just, yeah, that code is a bit different depending on where you are. So how to become a provider. So there's an online course that's available through the Learning Hub. It takes a few hours to do. Save yourself a little frustration. Do not try to do it on a Mac computer. It is not going to be easy for you. Do it on a PC. I did not make that mistake, but I heard from Sarah that it was extremely frustrating for her.
And resulted in me not doing MAID provisions for 1.5 years.
But then she figured it out. And so now that course isn't mandatory unless you're going to be doing your MAID provisions in an Interior Health facility, like if you want to do them in an acute care setting. And so that is required to get privileges to do MAID provisions in the hospital. And so then you have to apply to get your privileges if you want to be doing them, yeah, in the acute care setting. And so if you are wanting to become a provider, it's best to go to a provision with a mentor, so someone who has obviously been doing provisions in the past. And so then they can sort of walk you through it all. And then to do one on your own with an experienced MAID provider there with you. So now I'm going to pass the baton or microphone back to Sarah.
Thank you, Andrew. So I'd like to take everybody through what the current experience within BC has been with respect to MAID. As of 2019, 2.5% of all deaths happened by MAID, but there's a lot of regional variability within British Columbia, and they've got quite a robust data collection system. Currently within Vancouver Island Health Authority, MAID deaths represent 7% of total deaths, whereas within IH in 2019, it was 1.5% of all of the deaths. Now, the next set of slides, I really want to send out an enormous thank you to Katie and Olga at the MAID Coordination Center and Janine, who have reviewed all of the MAID provisions and provide me with all of this data. Just to give you an idea of how busy the MAID Coordination Center is, currently Katie and Olga are fielding between 10 and 15 requests for information per day. And since inception, the group at the MAID Coordination Center has been tracking statistics, giving us all of the next number of slides regarding who's accessing MAID and all. So all of these slides are courtesy of the MAID office. And what I want you to see on this slide here is this is the number of completed patient requests that we are getting within Interior Health. So back in 2016, that was when MAID first became an option. And now we are getting 125 requests per quarter, which is a major increase and represents between 2018 here, 2019 and 2019-2020, a 47% increase in the number of requests, completed requests. Now, not everybody who requests MAID, as Andrew indicated, follows through to provision, but this once again shows you that quarter upon quarter we're seeing a steady increase in the number of patients that are requesting MAID. And if I go back to 2017, 2018, they were organizing 0.9 provisions per week. In 2019, 2020, it was up to 5.1 provisions per week. And if we were to carry this over to into this next quarters, in July 2020, they coordinated 7.4 provisions per week, and in August, 7.9 provisions. So that represents more than a 7-fold increase in the number of patients that are following through to MAID. Not everybody who applies for MAID is considered eligible. And when we look back over the last 2 years, because we haven't been tracking this for 4 years, about 8.5% of patients are rejected. And when you look at who these 57 patients represent, it's felt that 71% of the patients were not able to provide consent. 19, their death was not foreseeable, and 8% of those patients were not in a state of advanced decline. The question about why patients they put in the request, but the MAID is not performed. When you look at that data, the most common reason is that the person died before the MAID provision could be provided, or that the patient was ineligible at the time, often due to a loss of capacity. Very rarely a patient will withdraw their request for MAID. Sorry about that. Now you might ask, well, who is asking for MAID? It's a fairly even split. male to female, both those who are requesting and those who are receiving. Most of the patients are quite elderly at the age of 74, but there's really quite a large range there, with the youngest that is, I think, my patient at 20, and this person had 2 failed liver transplants and was not eligible for a 3rd liver transplant. When you look at the underlying diagnoses that led to people wanting to have MAID, as one would expect with an elderly group, 2/3 of those patients have cancer. And then I kind of think of it as being 10%, 10%, 10%. Same number who have neurologic problems like ALS or Parkinson's, end-stage pulmonary disease, end-stage heart disease, and then a few other grab bag disease processes. Another question that gets asked is what percentage of MAIDs are expedited, and it's though the number of patients that are having an expedited provision is increasing year over year, the percentage remains constant at about 1/4 of the patients have an expedited provision, which means it happens less than 10 days after the patient signed the forms. People often wonder where these are happening, where the provision is happening based on the location. Most of the patients are out in the community, and this happens within their own home. About 1/3 happen within acute care, and then a small percentage happen within hospice and long-term care beds. When you look at it by administrative area, I would say that MAID, access to MAID is not equal across interior health, or it might be that requests for MAID is not equal across interior health, and I can't answer which one that is. Here in the central Okanagan, which is predominantly kind of Kelowna, 32% of the MAID's provisions happen here. In the South Okanagan, it's about 18%. The North Okanagan, which has a similar population to the South Okanagan, is only 14%. And what continues to surprise me is that Kamloops and the Thompson Caribou have such low percentages of MAID medical assistance in dying. And I don't know if that's that patients aren't interested in or that they don't realize that that is an option. This will be a slide that I can't imagine I'll have to show this in future. There were, in past, patients had to be moved at the time of MAID provision, and it represented, it was because the place where the patient was would not allow a MAID provision to happen. But now within hospice, all of the hospices within interior health and the vast majority of the long-term care facilities, if they are accepting more than 50% of their funding, they must allow MAID to happen on site. So just a couple of final comments from Andrew.
So this booklet here, A Shared Journey, was put out in the spring, and so it was put together by the MAID Coordination Center. I think this booklet is completely wonderful and just an amazing resource for both patients and families who are potentially interested in MAID or who are going through with MAID. And it walks everybody through everything from the filling in the assessment, filling in the patient request to what the patient can expect on the day of, what family members can expect on the day of. And then there is also resources in this booklet for family members and friends. So for grief and bereavement for post-MAID. And so this is available from the IH-MAID public webpage, and you can download it or print it. And yeah, I would strongly encourage physicians to take a look at this and offer it to their patients if they're thinking about MAID. And so a big thank you to our Interior Health MAID team. All of these people here have put in a tremendous amount of work to just get MAID out there and educate people. And yeah, thank you everyone on the team. And so future educational sessions regarding MAID. So October 22nd, there's going to be a Zoom meeting with myself and Dr. And this is yeah, a recruitment session for people who are interested in becoming MAID assessors and providers. We will go through cases and yeah, teach people if they are interested. The next one is October 28th, and this is going to be challenging cases presented by experienced MAID providers within Interior Health. And then organ donation post-MAID. So what is involved? This is evolving in Interior Health, and the new, or this date is hot off the press, November 25th, 2020. And the last one, which is to be announced, is ramifications of Bill C-7, and I imagine that will be sometime in December probably. So now we'll turn the floor over to questions.
So if people have questions, you'll notice that at the bottom of the screen, there's a chat function. Feel free to put your first name in, and we'll connect, and you can ask your question or put your question right in the chat function. Okay. So Sarah and Andrew, this has been quite a journey over the last 2 years. What have you found has been the most significant change?
I think that for me, the most significant change has been the number of patients that come to me now asking about it, and that the public is more knowledgeable about medical assistance in dying. That's been, I think, the biggest change for me. And I think the volume of people that are asking for medical assistance in dying.
So I would agree with Sarah. Another big thing that I've noticed, which is I think is great, is the number of physicians that are getting involved. Like in Penticton, there it is. We have a very strong group of physicians and nurse practitioners who are involved in MAID. And yeah, I think that's great because it's more accessible to patients. And in the beginning, there weren't that many people or physicians involved. And yeah, now it's out there, and patients have access to it. So that would be, I think, the biggest thing for me is just the number of people who are, yeah.
Involved.
Thanks, yeah. Andrew. We have a question in the chat.
We are physical medicine and rehab specialists. I will just speak my comment from my perspective, but thank you for that. Case example, this morning I had a patient who I saw who has already gone with the MAID process. She has a progressive condition. So when I offered her various treatment modalities, she was fortunate in that she has private funding to access allied health. And I did ask her, I said, do we want to stop here? You know, I'm happy to stop here. Or do you want me to offer you what I think would help your function, your form, your mobility, your pain? So we were lucky that she had access to that allied support. One of my questions about this, it's just sort of a more theoretical question moving forward, is if patients have potential access to MAID, will they also have equitable access to, say, allied health resources, rehab services to improve what they may not even know they can improve? Thank you.
Andrew?
Yeah, so I think you've raised a very valid point. And so I would like to think that most of our patients here that have been given access to MAID do have access to the things that you mentioned. I would say that unfortunately, maybe in some of the more rural, remote areas that maybe they don't have access to those great resources. For myself, as I mentioned, when I am doing the assessments, either as the primary assessor or the provider, I like to make sure that they have access to basically everything that they can to help them with their disease process. So yeah, I like to make sure that they have at least tried.
And just to kind of give one or two examples, There was a patient that I assessed who had throat cancer and was having trouble swallowing, and the person didn't realize that they could have radiation and also a peg feeding tube put in. And in having that discussion, talking about all of the options, the person put aside, they had the option of MAID in their back pocket, but went ahead with further therapy. And Andrew and I share a patient who he's got a horrible peripheral neuropathy and a history of ischemic heart disease and has refused to have any invasive procedures done. And we continue to follow him along. I think it's now been almost 2 years that he has been accepted, but he's knowing that he has options has made, I'm using that MADE, made him find new balance in his world.
Are there any other questions? Just enter them into...
Jill Calder here.
There's a comment here from Paul. He says his biggest fear is that he'll be the only physician in town providing MAID. Do you find most communities have a buddy system with at least 2 docs? And when we are in a community that is stretched thin with primary care, it seems like a big commitment. Any comments?
Okay. Yeah, go for it.
So, Paul, thank you very much for your comment. And I completely see where you're coming from with this. When MAID started in 2016, I was the only physician providing MAID in Penticton, and I was stretched pretty thin. And that has, as I mentioned, turned to the opposite direction, and now we have lots of physicians involved. Do you know where, Paul, where are you, I wonder? Because so there is, the MAID Coordination Center can arrange for funding for physicians to travel to provide MAID. So I don't know exactly where you are, but if you were involved in MAID and you found you were stretched quite thin, I do suspect that the MAID Coordination Center would be able to help bring in providers to your area to do provisions if it was becoming too onerous for you. But yes, a buddy system would be great, and it's always good to have backup when you need it.
And that's also part of our plan with this recruitment session on October the 22nd. A flyer went out through Patricia inviting anybody who wishes to learn more about MAID assessment and provision to take part in that. And you can also contact either myself or Andrew, and we can forward that information. We're trying very hard to increase the number of assessors and providers due to the fact that the number of patients requesting is increasing. The other way that we have increased engagement is a bit of subterfuge, and that is that we do it every time I'm going to do an assessment or a provision. I involve the medical students within my within our region to be involved, and they then have infiltrated their family practice clinics, and it's become a more talked about concept within the South Okanagan.
Jill Calder here. Can you hear me?
Yes.
Yeah, I think I've managed to figure out the override that you guys have on your Zoom, but I'm going to break in again. Ruth Brickhouse has said a comment that Kamloops is a Kamloops physician. I'm not was yet. I'm still active. And in fact, most of those early 2016 assistance in dying was patients that I was involved with, because I have a heavy practice of ALS. As to why Kamloops is low, I think one would have to look at how these data sets were collected. I wouldn't mind it if the presenter was able to scroll back to where Kamloops only had 6. I think 6%. 6%. I think what we need to look at is, why is Kamloops a city and why are the others zones? So North Okanagan, South Central, they're not cities, they're zones. So if Kamloops only has the service provision as a city, why is that presentation not by city for the other health authorities? So that's one sort of my digity data collection brain goes to that. As to why, I think one thing we have here, which I have benefited from directly with all my patients with ALS, is a rather incredible working relationship with the home health and the palliative care unit that we have up the hill, the Marjorie Willoughby Snowden Hospice House. They have taken my ALS patients at the right time, given them what I've called a palliative planning admission. And with the palliative planning admission, the patient gets an understanding of what their symptom management can really be. And some of them will then choose to go home on that plan once it's set up. And so I've had a number of patients choose MAID, but then change their minds based on the palliative level of care being offered. So that may be one aspect to the ALS subpopulation. As to why our oncologic may be low, there may be a centralization of services occurring because the oncology center is out of Kelowna, and there may be more of an affiliation in that direction. I don't know. You need to subcategorize this by the diagnostic group and then also by the postal code of the supportive family. A lot of the patients move to where their family are in order to have the services provided, and that seems to happen in their ambulant phase and pre-contemplative phase of the medical assistance in dying. Those are my initial thoughts.
With respect to
John Souls here, if I can make a comment about rural places. If you look at provision of assistance in dying in jurisdictions around the world, the highest uptake tends to be in patients that are highly educated and in higher socioeconomic brackets. And so I suspect that there's multiple reasons why rural individuals don't partake of this as often. And certainly that's one of them. You know, when I was asked about this by the expert panel on assistance in dying several years back before the legislation, I sort of proposed that there'd probably be 1 or 2 a year in Clearwater, and that's really where I am, and that's kind of the numbers I've seen. So, you know, I'm not sure if it's different in other rural places, but I think it's a reflection in part of the socioeconomic and educational status of the patients. And so why do those people are less interested in it? It's a good question, but it certainly seems to be true in places like Washington, Oregon, and the Netherlands as well.
Yes, John, the data does support that, and I think that also supports the difference between Vancouver Island and the interior as well. And some of the data probably needs to be weighted on a capita basis as the straight percentages. But those are the factors. To me, the biggest change in that I've noticed is that I was at a presentation through the Cancer Center at the end of last year, and it was on end-of-life care with with the palliative care lead for the province and other individuals and researchers. And the essential consensus that came from this was that it is the patient's journey that we're here to support, and there's a role for medical assistance in dying in terms of the choices people have at the end of their lives. And that's a long way from the early conversations around this topic. So I see this as sort of the maturing of the conversation, right? And how do we integrate care and viewpoints and give people choices? And part of it is providing palliation and supporting people through this. And it's going to be a story that's going to be years in the unfolding as we go through various legislation and changes. So I want to thank people for attending this first grand rounds. There is an evaluation. There is a QR code that you can take a photo with your phone, and that will give you a link right to the evaluation. Or you can type a URL into your browser and be able to provide us with feedback. I'd like to thank Sarah and Andrew for providing up their time and their experience in sharing this with us. And this presentation will be available to everyone who's attended and will as well be posted at a site, and people will be informed with links as to how they can connect. So thank you very much, everyone. I wish you all a great end of your evening tonight. Enjoy your families, enjoy your time, and enjoy the fall. And the next grand rounds will be the third week of October. It will be Dr. Derek Pudster, Deputy Registrar for the College of Physicians and Surgeons, and he will take a look at wellness from the perspective of when there is a complaint against a physician and what changes are occurring that the college has a more human-centric approach. So thank you, everyone. I wish you all the best, and I want to thank the team who are responsible for providing this service. And as we can see, there's a lot more work that needs to be done given the way the curves are in terms of the growth in this area. So thank you and good night.